You know, every year I try to talk here about something that's vascular malformations, and I think this year I went really far, being brave, and tried to talk about vascular lesions of the spine. And first of all, I'll try to talk a little bit about the anatomy of the vessels of the spinal cord. So what do we need to supply when we're talking about vascular issues of the spinal cord? We need to supply the vertebral bodies, the paraspinal muscles, the dura, the nerve roots, and the spinal cord. Going to the beginning and a little bit of philosophy, we're all built from those breaks that calling metameric segments, just like this worm, and every metameric part of us is built from ectoderm, mesoderm, and endodermal elements. And if we concentrate and look at the spinal system, it consists of metameric grid of transversely oriented segmental vessels, and they're all connected by longitudinal channels of blood. So if we look at the most obvious way to look at it, and this is the thoracic area, each vertebral body, its ribs, the muscle, the nerves, all this dermatome is supposedly supplied by one segmental artery. So in the embryo, like in the beginning of everything, we have the dorsal and the ventral aorta, and then we have those segmental arteries going to this tube that is growing, the fetus and the neural tube and everything. And with time, there is gradual establishment of dominant longitudinal vessels that will lead to regression of some of the segmental vessels. So now we have more longitudinal vessels going along this creature or neural tube or whatever, and we have less and less segmental arteries going all the way to the center. And at some level, the segmental arteries persist in supplying the longitudinal artery. And this is the idea of it, and maybe it will be surprising for you, but where I'm coming from, we think it's all the way. It's also the basilar system and the pica and the vertebrals in the brain. They're all parts of this metameric segmental system. So this process in the spinal cord gives rise to the familiar, what we know in the adult, and this is what we're trying to talk about today, the appearance of the anterior spinal artery, which is one of the longitudinal arteries, and it is being supplied with some radiculomedullary feeders, which are remnants of those segmental arteries. And on the other hand, some of them will not go all the way to this longitudinal artery, and they will just supply the adjacent tissues of the column or of the spinal area. So we have segmental arteries trying to supply the cord or the anterior spinal artery, which we'll get to him, and they can come from every segment of the body. Vertebral artery, which is a longitudinal artery, the deep and ascending cervical, the intercostal and the lumbar, the iliolumbar and the sacral. All of them can send vessels to the cord, but not all the way. So not all segmental arteries have radiculomedullary artery or radiculopial feeders, and their location is unpredictable. We know that the human have about 6 to 10 radiculomedullary arteries. So we have 6 to 10 arteries going from the segmental into the anterior spinal. And people who do angiogram knows that most of them we don't see. Some of them are not in the resolution of the angiogram, but they exist. But not all the levels from the head till the sacrum have those supplies. And we know that the anterior and posterior spinal arteries along the cord have superficial anastomosing between them. So if this is the anterior spinal artery, and those are from the back, the posterior spinal arteries, they have a network of connections between them on the spine itself. So now we try to look at it, you know, more closely. Okay, so this is one segment. It's like I have a small place here. This is one segment, and we have the aorta, and we have two segmental arteries coming from the dorsal part of the aorta. And now if we look at one of them, which is a segmental artery, and it can be from the cervical, from the vertebral artery in the cervical area, it can be a segmental artery in the intercostal area, we will have a bifurcation. One of them will be the intercostal artery that's going to the rib and the muscles and all those less important thing. And then we have another branch that can be called the dorsal branch or the radicular branch from here, and he will go towards the spine or towards the column. And then this dorsal branch will go towards the, oh, I did something wrong now. I'm going back. Okay, and this dorsal branch will go towards the neural foramina, and first of all it will send branches to supply all the surrounding, like the epidural tissues and the dura and the muscles and the vertebral body. That will be the first thing, one issue. And then there will be the radicular artery. And the radicular artery is the artery that's going to the foramen and will supply the nerve root. Okay, so now we lost all the things that are outside and we go towards inside with the radicular artery towards the foramina and the nerve root. And then at some levels the radicular artery, which is becoming enlarged, will maintain what we talked before, the embryonic access to the longitudinal vessel, and he will supply the anterior spinal artery. And at this level we call him the radicular medullary artery, because he's going to what we call the medulla, which is the cord, which is like the brain. Okay, so if you have this level, when you see the radicular artery going into the spine, up into the anterior spinal artery, it's called the radicular medullary arteries. And we know that we have posterior spinal arteries. So if the radicular artery going along the posterior nerve root to the posterior spinal arteries, from some reason it's called radiculo-PL artery. So we have radicular medullary arteries to the anterior spinal artery, and we have radiculo-PL arteries that go into the posterior spinal arteries. And we have them only in certain levels that we don't really know to predict. We know usually where they are, but it's not a rule. So just for summary, we have the spinal cord, which is supplied by the anterior spinal artery and the posterior spinal arteries, and at some levels we will have radicular medullary and radicular PL supplied to that from segmental arteries all the way from head till sacrum. And then we have the nerve roots in the foramina, which are supplied by the radicular artery. And then we have the dura and the epidural elements that are supplied by radiculomeningeal arteries, which are branches of the radicular or the dorsal branch of the segmental artery. And then we have the vertebral body that gets this supply. So now looking at the anterior spinal artery, and it goes along the anterior sulcus of the cord, and it originates from the vertebral artery. The anterior spinal artery starts in the vertebral artery and goes all the way till the conus. And because it's a long way and it has a lot of tissue to supply, it gets reinforced from what we talked before, the radicular medullary arteries. So just few examples from angiograms. You see the catheter is here. This is the supreme intercostal in this case, and then you see the radicular medullary arteries. Sometimes we see the area, it penetrates the dura, it goes towards the spine, and then you see it going up and down. Here you see another example. This is the intercostal artery, and you see the area where it penetrates the dura, and you see it's coming down as the anterior spinal artery. And sometimes you see we're using non-subtracted images just to be sure that this is in the midline and it's going along the spinous process if the technician didn't put the patient, oblique. This is another example, and you see the catheter here, and again this is the segmental artery, and this is supplied to the anterior spinal artery. What's nice about this image is that you see the area of the conus where there are connections between the anterior spinal artery and the posterior spinal arteries, and there's like something we call the arterial basket at the end of the cord. And this is just to show you, we always see images with the anterior spinal artery, and most of the work we're going to do and the injections we're going to do are going to be like that. We're going to see like an intercostal or lumbar or some segmental artery with all those branches going to the vertebral body and the muscles, and there's nothing going into the center, into the anterior spinal or the cord. Just a little bit about venous. This is arterial phase. You inject, you see the anterior spinal artery going down, and if you wait, this is beautiful picture, you can almost see capillary enhancement of the cord. In the brain we have arterial phase and capillary phase and venous phase, and it's a bit difficult in the cord, but you can almost see capillary enhancement here, and then you see those superficial longitudinal median veins which are going to be very important with pathologies. So just only this about the veins. We have the intrinsic veins in the cord itself, and then they go to the superficial PL veins, which are the light blue surrounding the cord, which are the ones that are interested, and they will connect to go along the longitudinal medial spinal cord, and they will go out of the cord along the radicular medullary veins, the same way we have the radicular medullary artery, and from there into the epidural veins. And this is just to show you another example of the anterior spinal artery. You can see here a little bit of posterior spinal arteries, and then if you wait, you get a little bit of enhancement of the venous system. So lesions of the spine. It's a bit kind of difficult and complicated, and you have all kinds of ways to separate the vascular malformations. Now I'm talking about vascular malformations of the spine, and I can't see through this thing. And we can talk about genetic hereditary lesions, and you know, when we have a defect in the vascular cells like HHT, hereditary hemorrhagic telangiectasia. And those people will have, you know, brain AVMs, and they have those things on the membranes of the mouth and the nose, and they can have lung AVMs, and it's all over. There's something wrong with their vascular cells. Another way, groups is the metameric links, like we talked in the beginning, and the famous syndrome is Cobb syndrome. When you have a patient, he's got AVM of the spinal cord, and AVM of the vertebral body, and AVM in the muscles, and all this dermatome is thick, and he's got huge lesions in the same, more or less the same level. But the most common, and this is what we're going to talk about this lecture, is all those single, you know, lesions that we can find in the spinal cord, in the epidural space, along the nerve root, and we'll talk about them. Another way to look at the spinal malformation, and this is coming to be important for people who are doing diagnostic or imaging, is the differentiation between pile malformation and dural malformation. And I brought you this image from previous lecture I had here, probably with other residents, I hope, that was talking about brain malformations. And then we talked about the brain AVM, which is a subpial lesion or almost an intraaxial lesion, and it's very easy to see that on an axial imaging. In comparison to the dural malformations, which are happening along the dura, and this is why it's difficult to see them. And it's the same idea along the spinal cord. You have the intramedullary or perimedullary lesions that are going to be more obvious to see in comparison to the lesions that are happening in the dura. So, if we look at all the important what's happening. The family, so we have the dural lesions, the perimedullary or intramedullary, which are like the intraaxial brain, subpial brain AVMs, and then we have the extradural lesions. So we'll start with those, with what we call spinal cord AVMs, and it can be, as we said, intramedullary or perimedullary lesion, and it's going to be fed, like we said, by the arteries, like PL arteries in the brain, like the carotid that's going to a brain AVM. So it's going to be fed by the radiculo-PL, the radiculomedullary, and the spinal arteries of the cord. And it's going to be drained into the spinal cord veins. And it can be a fistula, that means a straight hole between an artery and a vein, things that we see more in kids, or a glomerular type, again, like in the brain, like a nidus type AVM. The patients are going to present with paresthesia, weakness of the legs, usually diffuse back pain, which is interesting. A lot of them have back pains, and the symptoms can develop slowly or they can be very abrupt. And why? Obviously because those patients have lesions in the cord. They can have hemorrhage in the cord. They can have an intranidal aneurysm that bled. They can have thrombosis of the vein, and they will bleed into the cord. Again, the nidus itself can behave like a space-occupying lesion and compress things. And then we have the issue of venous congestion and maybe still phenomena, which I'm personally not sure. MRI, we're going to see in the spinal cord AVM, we're supposed to see this conglomerate, this nidus of dilated vessels that are going to look like signal voids on the T2. Sometimes we have contrast enhancement of those vessels, and we'll get to that. And then we have the signs of venous congestion with intramedullary hyperintense signal on the T2. Sometimes we even see hemorrhage in the cord, which this is helpful for us to understand. This lesion has to be intramedullary lesion. And sometimes we're trying to use MRA in order to find the level. So this is just one example. You can see here on the T2 this conglomerate of vessels with those large draining veins. You can see it here larger. And this is how it looks on an angiogram. Again, this is injection to its segmental artery. You see the radiculomedullary artery. You see the antiospinal artery goes down. It's not in the level where it happened. It can be everywhere. And then it drains into this vein. This is, I think, a beautiful example. You see the catheter here. This is a T9 intercostal. You see the vessel coming, as we said, this dorsal radicular artery going towards the spine. And then we have radiculomedullary artery who's supplying the antiospinal artery. And we have a radiculo-PL artery which is supplying the postiospinal. And you see this nidus of vessels and then this huge draining vein. And this is how this lesion look on the MRI. So again, you see those vessels, you see that there's something happening in the cord, maybe a hemorrhage, maybe an old hemorrhage. And this is how it looks on surgery. Those are the dilated veins that you see on the cord. I tried to put those two images together. So this is the draining vein, and this is the nidus here and here. This is the fistula type AVM. This is injection to T8. You see nothing. But if you go down and down to the conus, you see that there's a straight connection between the artery, the anterospinal artery, and a draining vein. So this is a fistula type spinal cord AVM supplied by the anterospinal artery, and this is the imaging of it. Again, you see the edema in the cord, you see the dilated vessels, and on MRI you can see the segmental artery, which is enlarged. Treatment. We don't have really, I mean, it's rare diseases, and we don't know really what's going to happen with those patients. Let's say you just find someone with an intramedullary AVM. We don't know the risk of hemorrhage or what's the chances that he will develop edema. Usually we find them only when there's symptomatic, and we know that if we treat them, we'll stop the deterioration. That we know for sure. How to treat them? Usually spinal cord AVMs are more, not easier, it's not the right word, but probably endovascular treatment is better for them, using whatever you use, glue, onyx coils. I don't think it's so important here. If it's a nidus type like AVM, so usually we inject some kind of glue, onyx glue, because we want to fill this cast of vessels. And if it's a perimedullary fistula, all the options, if you can get there and even put coils, it's going to be good. The most important to understand is that you have to occlude the venous part. You have to get into the vein and close it, because as long as the vein is open, it's going to recruit new vessel and it's going to come back. And we see patients coming back, complaining their symptoms come back, and if we can do it, so we need to send the patient to surgery. It's not so sad. This is not my case. It's an 18-year-old female. This is MRI. T2, you see this conglomerate of vessel. This is on angiogram. You see the arteries supplying it and the draining veins. Just to show you an example, this is selective injections to the vessels supplying it. You see parts of the malformation, and here the draining vein. And this is after someone did embolization for that with glue. So you see that part of this lesion is going and disappearing. It's a complicated and dangerous kind of procedure. So that was spinal AVM. So now we will go to the dural malformation, which is some kind of arteriovenous fistula. It will be fed by the radiculomeningeal arteries, like in the brain. It's like a dural artery, and it will be drained into perimedullary veins and radicular veins. So this is the most frequent vascular malformation of the spine. This is what you can catch on an MRI, and it's about 70 to 80% of all the shunts in the spine. It's probably an acquired disease. It's not like a genetic something, and it's happening usually in elderly people, really like 70, 80 years, 60 years old, usually men, 5 times more than women, and it's usually in the thoracolumbar region. We call it a treatable disease if we catch it, and potentially reversible form of myelopathy, but we'll get to that. So what's happening here? In comparison to the perimedullary or intramedullary spinal AVM, here the lesion is almost outside. So this is the aorta, and this is the segmental artery, and this is the artery that's going into the foramina towards the nerve root. And the fistula happens here someplace. It's intradural in the foramina, and from there it drains into the perimedullary spinal venous system. And this is the problem. But the lesion is, it's a side. And if you look at it here, this is the catheter, and you see here the area of the fistula. It's in the area of the foramen, and then everything you see is just those huge draining veins. So what's happening? The shunt is inside the dura, but it's close to the spinal nerve root. It's supplied by radiculomeningeal artery, and it drains into the spinal veins, and then we have the pressure in the spinal veins is getting higher and higher, and then we get venous congestion, and then we get intramedullary edema, and the patient develops myelopathy. So what are going to be the symptoms? So usually it's what we call congestive progressive myelopathy, and the patient will develop the symptoms along a long time, how do you say it, slowly and with long time, and he's going to present with hypoesthesia or paresthesia. They can have paraparesis, they will have weakness of the lower limbs, and one of the clues for the clinicians to think about dural fistula, if the patient has a combination of lower motor problems and upper motor problems in comparison just to lower if it's like spinal stenosis. Again, as I said, it's very interesting, but they all complain of back pain and pain in the legs after they walk, and this is why they're all being confused with spinal stenosis. And most of the patients we see are patients that already had 1 or 2 operations for spinal stenosis before they get to the right diagnosis, and they get issues with impotence and sphincter disturbances, which is really disturbing. So we said it's usually slowly progressive. Sometimes it can be acute. Sometimes they give you a story that something happened and they started feeling bad. A lot of them had previous surgeries for orthopedic spinal stenosis, herniated disc and stuff like that. And we know that if we won't treat them, it will go and become worse, and they all end up on wheelchairs and sphincter issues. So MRI, what we see here is we don't see those conglomerate, the vessel, but we see cord edema in multiple levels, usually in the thoracolumbar area. We see perimedullary dilated vessels, which are usually dorsal, but it can be also in the anterior part of the cord. The cord will be in the beginning of the disease, or for sometimes it will be swollen, but there are, situation when you get to the end stage where the cord is becoming atrophy. If you inject contrast, there is enhancement of the cord. And we had a patient in my hospital that was supposed to have a cord biopsy the next day because there was enhancement of the cord. So we all need to be careful about it. It's just congestion and the contrast is standing there, and you can see enhancement usually at the end towards the conus. And if people have small shunts or something, if they come back after treatment and they have like a residua or recurrence and they have small shunts, sometimes you can see the vessels only after injection of contrast. And then we have to remember that spinal dural AV fistula can be without prominent vessels, which is very difficult for us to diagnose for sure. And then spinal dural AV fistula with prominent vessels can be in a patient that has no symptoms and still not edema. And this is probably just time issues, if you wait, you will have edema and symptoms. So this is an example of an 83-year-old person he complained mainly of back pain, and he had urinary incontinence, so you see the cord edema. You don't see those niduses because there's no nidus here. You just see those large draining veins that sometimes they're a bit enhancing. And this is how it looks on the angiogram. The fistula is here in the area of the foramen, and then you just get those perimedullary draining veins causing the congestion. This is just another example. It's the same picture here. The vessels are really pronounced after contrast injection. The fistula is here, and this is just veins in the canal. And one thing which is very frustrating, I think, for us is that the location of the pathological vessels you see on the MRI or the level of the edema have no connection to the level of the fistula. And this is a big issue for us, and we're trying now to do MRAs and CTAs in order to find where is the vessel that's going to the fistula. And if not, we just have to spend a lot of time doing spinal angiograms and looking for the area of the fistula all over from upstairs till downstairs. Treatment, 2 options, 2 good options, surgery and endovascular. If the surgeons will find the fistula, if they find the vein and they close it, they cure the patient. So it's about 90–95% of cure, because if they get there, they do it. Endovascular therapy is obviously great, but for us it's a bit more difficult to get there. We need to do all this way and all those turns. So if we get into to the vein, so it's going to be good, but sometimes we're a bit too far and we don't really fill the vein with glue, and then the patients come back. The aim is to occlude the fistula and the proximal segment of the venous part, and we said that. We know that usually most of the patient, the progression stops, but this is the last thing I can do about good news. Most of them don't improve so much. We say that about 2/3 of them, the motor symptoms will get better, only 1/3 will improve their sensory, and we know that impotence and sphincter disturbances are very difficult to cure or to get better. And some of us always say that it depends on the time we caught you. I don't know, it's not really written in the literature, but it's kind of logic. So the catheter is here. You see this intercostal artery. You see here the fistula. This is the vein going and draining into the brain, into the spine. And this is the cast of the glue after the injection, filling kind of a long part of the vein. Okay, so that was about dural fistulas. And this is just one example of epidural shunts, but I'm not going to talk about that. It's really rare diseases, but it's really nice. You see those huge epidural veins, they look like a ladder, and you need to recognize them. So just a few more example cases and I finish. So this is a 12-year-old boy that had sudden onset of weakness in the lower limbs, and you just have T2 here because I was a bit lazy, and you see this signal here, and what can that be? They won't get $2,000. Differential diagnosis, hyper-intense signal in the cord, the boy is not walking. What's the most common thing? Yeah, myelitis. What else? So someone said myelitis. Okay, demyelinating disease. What else? Foliat. Okay. Nothing else. Is it a tumor? No. I mean, it's talk about vascular lesions. God. Okay, so we'll go on. So let's say I showed you this, and this is an ADC. So what does the patient can have? Or at least we should think about it. What? Stroke. Good. It might be a spinal infarct, okay? You know, it's not examination from our hospital, and the diffusion was a bit confusing, but let's say I have a good diffusion of the spine, which I think we're now starting to have, and it's a very important tool. And this is, so one option to think is myelitis, the other option is to think about an infarct. You know, he's a boy, maybe he's got dissection or something, and he's got a stroke. I wanted to show you something nice about this case. This is two sagittal views of this boy. It's steer, isn't it? Do you see another thing, another problem in the images? Someone? Yeah, exactly. Do you see the vertebral body here? This is the clue. This is one of the nicest cases I think we have, and I think it's a good lesson. If you just remember that, I think it's great lecture. If you're suspecting a cord infarct and you have a lesion in the vertebral body that is occupying only one half of the vertebra, you see, I didn't have a coronal because we didn't do the examination, but believe me, it's the same examination, it's the same patient. This is one part of the vertebral body, and this is the other part, this vertebral body, and it's just only half of the vertebra is sick. It's a cord infarct. There's no other lesion in the world that will occupy or will harm the vertebral body, only half of it. It's just because the segmental artery that's coming from the aorta is supplying one half of the vertebral body. So this is 100% a cord infarct in a 12-year-old boy. Okay, so cord infarcts are rare. That's why we're not so good in it. And the reasons, not explanation, the reasons for that are a lot. There you have, the obvious is dissection, atherosclerotic disease of the vertebral arteries, hypotension, dissecting aneurysm. Obviously, surgery is the most common. Fibrocartilage embolization, with a bizarre reason, epidural anesthesia, vasculitis, and trauma. So it's probably happening. Maybe we're even missing some of them. In the literature, they say the etiology is known in 60% of the patients. I don't think we're good. I mean, I don't think I'm there. The symptoms, it's going to start really quick. Usually, again, they have pain for some reason. They will have flaccid paraparesis. They will have bladder dysfunction. And usually, just because most of the time it's the anterior spinal artery, they will have preservation of the posterior columns. I mean, they will have normal proprioception, light touch, and vibrant sensation. Imaging, so usually we have this hyper intense along the cord. We say it's in the anterior part of the cord. It's a bit tapering like that. In the subacute phase, we will have contrast enhancement, usually not in the beginning. In this kid, we didn't have contrast enhancement. And in some of them, we have the snake eyes, which we know is, we see snake eyes in different diseases, yeah, in degenerative disease and spinal stenosis, but also in a cord infarct, we can see those two eyes of the snake, again, because of the vulnerability of the gray matter. Okay, I think it's, no, almost the last. Okay, so what's that? Okay, so that's tumor blush. I mean, it's not really a vascular malformation, but this is why I called it vascular lesions. An infarct is not a vascular malformation, but this is just a space-occupying lesion that they ask us to do embolization before surgery. And you see that there is, do you see? That there is opacification here of radiculomedullary artery and enhancement of the anterior spinal artery. This is another example of a 52-year-old male with renal cell carcinoma. He had huge tumor here compressing the cord, and they wanted to take him to operation. So you see, you put the catheter in one level. This is T8, they said. So this is T8. It was T7, T6, and T8. And you see this huge tumor blush going from the area of the cord all the way the paraspinal muscles. And then we tried to help them a little bit with injection of glue. And then the last case, it's a young person that's appeared with this space-occupying lesion. It's enhancing. The T1 was hypo-intense, and it's really enhancing. And this is how it looks on the T2. I'm sure what you want to see is an angiogram. It's obvious. So this is how it looks on an angiogram. So what is it? But just a clue, this is another patient with the same disease. So you see all those lesions, and this is an angiogram that he used to do in the past for those tumors. So what is it? Okay, this is hemangioblastoma, yeah? Again, in the past, I think we did more, I don't know, Paul is here. We used to do more embolization for those, but now we're doing less and less, and they just operate them. But this is how we have angiograms of them, and you can see here multiple hemangioblastomas along the spine. You can see here one tiny hemangioblastoma and how it's being supplied by the anterior spinal artery. It's beautiful, and this is part of von Hippel-Lindau syndrome. Thank you very much.